Hello, everyone, and welcome to today's webinar, Challenges in Diabetic Food Ulcer Management and the Impact of COVID-19. My name is Maria Lopez, and I'm the Marketing Manager at Mölnlycke. Before we get started, please submit your questions by typing them into the Q&A box of the control panel. You may submit your questions at any time. We'll collect them and address them during the Q&A portion at the end. I'm very pleased to introduce our guest, Michele Labbie. Michele is a nurse practitioner who is passionate about complex wound management in chronic disease management, particularly in people with lower leg ulcerations and diabetic food complications. She has focused her expertise in this area for over 30 years and is actively involved in clinical research, pathway and practice guideline development, and in implementation of evidence-based care. Michele practices in an outpatient wound clinic and is involved in ambulatory, intravenous, and infusion therapy. In addition to her practice, Michele provides wound and infection management education to healthcare professionals in numerous settings and is also an instructor in the Wound Certificate Program at McEwan University in Edmonton. Welcome, Michele. It's a pleasure to have you here.
Thank you for having me, Maria, and welcome everybody tonight. I know it's a beautiful day, and so I'll try and keep you entertained, and we'll end on time so you can enjoy the rest of your evening. We were talking before; it's the longest day of the year, so that's very nice and a little bit depressing all at the same time. So tonight, I want to talk to you about challenges in diabetic foot ulcer management, and really what we've seen or what I've seen in my practice resulting from COVID-19. So our objectives for tonight are to look at identify the risks that people face with diabetic foot complications, to look at the impact of the pandemic on the management of diabetic foot complications, and then to share challenges and real life experiences that I've encountered during this last 2.5 years. So some statistics to start it off: 60% of people with a foot ulcer have their ulcer recur within 3 years. And we think of diabetic foot ulcers as being remission rather than as being closed or healed because of that recurrence rate. 85% of amputations related to diabetes are preceded by a foot ulcer. And approximately 20% of moderate to severe diabetic foot infections lead to some level of amputation. These statistics, I always, every time I look at them or read them, I find them very disheartening. And what I do because I want to change these statistics. And I believe that many of us that are doing this type of work, this is really why we're doing it. 27.3% of people with diabetes and a lower limb amputation will not be alive in 1 year. Of those people that are alive after a year, 63.2 will not be alive at 5 years post-amputation. And these are real statistics that we see in real time, and certainly something we're trying to change. The 5-year survival rate for someone who's had an amputation related to diabetes is worse than that of most common cancers. And we see lots of information in the media and lots of advertising and funds that are raised for cancer research and cancer care, and don't diminish that at all, but certainly our people with diabetes are sitting in a very precarious spot. So what are the costs? This is some work that was done in 2015, and I can't imagine that it has gotten better since this time. In fact, the costs are probably more. The direct cost of treating a diabetic foot complication exceeds the treatment for most or many common cancers. And Wounds Canada reported that treating one foot ulcer costs about $8,000, and if that diabetic foot ulcer becomes infected, the cost more than doubles. So what has been the impact of COVID-19? Certainly, I don't think any of us expected it to go on as long as it has. And we know that delayed wound care can lead to more serious infections, increased hospitalizations, and rates of amputation. That's something that we knew pre-pandemic. However, preliminary data that has been collected, and this was from 2020, shown that there's been a marked increase in the rate of untreated diabetic wounds and wound-related amputations since the pandemic began. And indeed, patients are admitted with a diabetic foot ulcer had more than 3 times the risk of an amputation related to that foot ulcer compared to those same people in 2019. So there were a number of threats that we saw during the pandemic, and indeed some of these still seem to be lingering. We had lab tests that were put on hold, so a lot of diabetes monitoring wasn't done. Routine investigations were put on hold. People weren't getting x-rays, getting pad screens to have their circulation assessed, MRIs. Routine non-invasive procedures were put on hold. So thinking about things like interventional radiology, and all non-emergency surgical procedures were put on hold. So we had people that perhaps were waiting for a vascular bypass, or were having something as simple as having hammer toes fixed, that were unable to have that done during the pandemic. And all non-emergency minor surgical procedures were put on hold. So many things were put on hold. And during the pandemic, many of these delays were always attributed to COVID-19. During that time, there were a number of different ways that people were dealt with, and the way that consultations were conducted. And so we know that many face-to-face visits were canceled. In our clinic, we had redeployment of staff and closure of our wound clinic once, and then staff deployed 3 times after that. But really, most of it was done by telephone. We resorted to texting of pictures on facility devices. We had one phone for our entire clinic, and so that was a busy little phone in trying to help people out. And phone care became the norm, and even home care. There was people were not being seen in their homes, and really were on their own to a great extent. Telemedicine with video consult was available, and I think that was one of the positives that came out of COVID, is that there was more telemedicine than went on. There have been there's negatives to that as well, but I think there are some positives going forward in how we can conduct some of our business. But certainly that in-person visiting is very, very important. Another thing that happened is when many businesses were closed and community services halted, and sadly, a number of those businesses never reopened, or services just became harder to access. So people were unable to access things like specialty devices like air casts, or having footwear or orthotics supplied, or even having adjustments to what they had. It was difficult for them to access dressing supplies. They didn't know where to get dressings or where to purchase them. There was really no access to foot care services, and this really was something that we found to be very, very difficult. I had a number of calls from elderly who lived alone we'd seen previously in our clinic, who just didn't know what to do. They needed nail care, they needed callus care, and they really had no one to help them, and they couldn't access service. As I said, the home nursing services were certainly restricted, and that it's been a slow return. There was also a real element of fear. People were, and they still remain, afraid. People with diabetes, those that were immunocompromised, the elderly, they were afraid of COVID-19 exposure, afraid to come to hospitals, to come to outpatient settings, afraid of having to be hospitalized because they would be, they would be alienated from any contact in hospital, and they were afraid of being exposed to people with COVID. And so we saw that real element of fear, and are seeing that even now. As we go through some cases, we'll talk about some of that. So what I would like to do is we're going to go through a few case examples just to share my experience during COVID, and to sort of bring forward what remains very, very important for people with diabetes and lower leg complications. So this was a fellow, 73 years old. He'd had a prior forefoot amputation, as you can see. Late 2019, just before the pandemic, he was treated for an osteomyelitis of this site. He had all of his, his wound management was optimized. He lives in a rural location, so he was being seen by home care and coming to our clinic weekly for considerable sharp debridement, advanced dressings, excuse me, we were optimizing offloading. He was into an air cast walker. And we did that until such time as we could get him into total contact casting. And, around Christmas time is never the best time to start casting. So that was something we were going to start in the new year. He had the respiratory therapist see him because of a smoking history and ongoing smoking. Dietitian saw him, and we really didn't see a lot of barriers to moving towards even more optimized care and getting him into casting. And the wound was on his left foot, which, as you know, if you deal with people with lower leg complications, it's much easier if it's on their left foot than their right, because they can drive without worrying about insurance and wearing devices intermittently for driving purposes. So in February, beginning of February, total contact casting was started. You can see on the left that he was aggressively sharp debrided. That would be me. And you can see he's had some silver nitrate to the area because of bleeding. That was his first cast application. The second cast, so the first cast change, was 2 days later to monitor how he was doing in that cast. And you can see by February 13th, actually only the third cast, his wound had almost healed. And this is a wound that had been present for a very long time. It took a lot of engagement and work to get him to a place where he was ready to offload. Certainly you can see that the casting was very effective, and with that wound almost closed in 9 days. February 20th, we did leave him in the cast for a couple more weeks just to let that area mature a little bit more. And in fact, it was continued until March 12th to facilitate that scar maturation to some degree. His current orthotics and shoes were modified to facilitate maintenance of that wound until his custom shoes and orthotics were made. So he was transitioned to foot care, to his footwear with ongoing monitoring and callus management in our clinic while he waited for his custom shoes to come, which typically were taking, 1 to 2 months at that time. And again, lots of self-care education and support with ongoing home care as well. Then, of course, we had COVID-19. We didn't really know what that would mean. And so that was a scary time. I think many things shut down. So his custom footwear and total contact orthosis were delayed with the vendor actually closing for some period of time after that. And it was unsure when that delivery would actually occur. So during that time, we had telephone monitoring. He texted us pictures to the clinic phone. And for him, he was actually lucky enough to be able to text. Many of our elderly patients weren't able to do so, and we're trying to describe on the phone what it looked like. He was managing his own callus and staying home, lived alone. Home care was no longer coming to see him. As I said, his foot was on hold. And he did call to say that the callus had built up. And in fact, it looked black now, and it had began to drain. He did have some dressing supplies on hand, which we, instructed him how to use and what to do. He was offloading the most that he could. And of comment, his smoking did increase during that time, I think, as it did for many people when they were isolated at home with the stress of everything that was going on. Our wound clinic was closed at that time, but I brought him into our IV clinic, which was open as an urgent patient. So as you can see, just really debrided down that callus that had built such to where we could manage it, or that he could manage it until we could see him again. And so what were the strategies we used to get him through? And I think that we all evolved those strategies as COVID came along. We tried to choose dressings that were simpler to apply. So trying to choose foam dressings that already had an antimicrobial in them, so that people who didn't usually do their dressings, and in his case, home care did most of his care, it was simple enough for him to put a foam dressing with an antimicrobial in it onto the wound and to tape it there. We tried to ensure that patients had supplies, so when they did come in, we gave them extra supplies because they couldn't access those. We tried to reinforce, how they could manage their own callus, the importance of offloading, and really going over when they needed to call to say that it was really urgent for them to see us. And really that hemorrhagic callus really is an urgent case, but it became very hard to see all of those people during that time. And so as you can see, and I'll talk about that a little bit later, we use drywall screen in our clinic, 120 or 150 grit, and teach patients to sand their own callus. And I'll talk more about where to find that later if you're unfamiliar. And then supporting using, moisturizers like Attractane that have urea in them to help keep the callus down. And indeed, we were sending things home with people where we might not have done that before or have stopped doing now with access to better services again. So his callus continued to build. You can see the wound was beginning to deteriorate. We couldn't keep ahead of it. And he was, as I said, on his own out in the community without home services. And so we considered, we moved to transitioning to a real wound maintenance goal about switching those strategies from looking at healing to just trying to keep it from getting worse, and really trying to support him in that. So teaching him how to paint his wound with iodine to try and dry it and put a nice breathable dressing over top that was simple to apply like Mepor, just plain gauze and tape so that it was very breathable, and trying to dry that out because he was having increasing issues keeping that down. Also then looking at bacterial burden and looking at prescribing antibiotics when needed. Finally, he did have some good news. Businesses reopened, or at least in part, and his vendor was able to get his custom shoes and orthotics in. So he was really, really happy about that. He was still doing most of his own self-care with some home care services. He was unable to continue care in our outpatient wound clinic because he was having trouble getting out, and he remained fairly isolated in his own community. So for him, he continued to struggle with access to service, doing much of his own care. We heard less from him, and indeed, he ended up losing that leg later that year. And so just sort of reiterating the statistics for you, because in his case, this certainly was the truth. And had it not been COVID, I don't think that this would have happened. I do have a second case, and this is a 68-year-old lady with long-standing diabetes presented to the emergency with a complex infection to her foot. Both of these patients were type 2 diabetics. And she said, you can see that she had a large blister on the bottom of her left foot that had been incised by the emerge physician and allowed to drain. And when I went to see her, she said, I thought it would get better. I was afraid to come to the emergency because my family finally made me. And she was really quite ill at that time. And so I did come to see her. She was on IV antibiotics, and had a good look at this. And if you look here, here's my little pointer. You can see here we have a shadowing of this large blister all the way around, but we have here what you would, a bit of a hemorrhagic callus that would be somewhat concerning. So when looking a little further into her foot, I deroofed that blister, and indeed where that hemorrhagic callus was, there was a wound there with a foreign body. And so there was a rock that I removed at that time. You can see it was quite a large rock, 1 centimeter, and it had been there for some time. She was quite ill, so she was transferred. This is a small emergency room, so she was transferred to a tertiary care center. And she was admitted to orthopedics. And this was really very interesting and really spoke to how things were at that time and, the ordeals that people went through. And this was her actual OR note. She's aware that this could potentially cost her the foot. And they even comment that this is a first diabetic foot complications. And so truly, if we hadn't been in that time and fear hadn't been such an issue, she would have likely, or she most certainly would have sought care much earlier than she did. And then, she ended up with 2 surgical debridements after that time. Cleanouts were performed. She was put on, extended IV antibiotics for bone infection, followed by orthopedics and ID. And it took, it was before the 3rd attempt before her wound was closed. Again, she lives quite rurally, so she was transitioned to home care at that time. So we lost track of her, but I'm hopeful that she's kept that foot. The last client that I want to talk to you about was, was a patient of ours for quite a long time, only 53 years old at the time. So he was still was working or trying to work. Again, lives quite rurally, an hour and a half from our services. He was admitted to our wound clinic back in 2017 for this non-healing foot ulcer. He ended up having a first ray amputation of the right foot within a year. He had irrigation and a 5th ray amputation shortly after that. And by, April 2019, he'd had a right transmetatarsal amputation of that right foot. And so we were working on trying to address that wound for him. So, if you deal with lower extremity complications, that these people can be very difficult to deal with. Really, we tried anything we could think of, a plethora of dressings, anything that we had, we tried. We did total contact cast him from September 24th to November 27th, and that's 2019. So shortly before COVID, and we did get that wound to close. We tried a real slow transition to therapeutic footwear and total contact orthosis, from an air cast walker out of the cast and trying to transition. But we really had a really difficult time maintaining that wound closure outside of that total contact casting. And remember, total contact casting is a really good intimate contact with that person's foot, where an air cast walker is really not that intimate. So we had real trouble with that. But we did try and keep him mostly in the air cast walker. He couldn't be casted with TCC endlessly. So again, as you can see, moving into Christmas season and all of those things, without staff to maintain that, he went into the air cast walker. He ended up doing, we ended up doing ongoing callus management with him. He was using the drywall screen at home. He was using, appropriate moisturizers, and he was seeing us in clinic weekly during that time. So he would come in. You can see here, he'd have minor hemorrhagic callus, doing the best he could to manage that. We would sort of par that down a little bit more from him, and we sort of kept him status quo while we were waiting for this custom footwear, because just therapeutic off-the-shelf footwear with total contact orthotics or orthosis just weren't cutting it. He needed the custom. So he finally had an appointment to pick up his new shoes on March 19th, 2020. But honestly, the vendor closed the day before or a day or two before. And so that appointment was canceled. So remembering that at that time, we also, clinics were closed. He had no more home care. He had no access to service. Physicians were only seeing most urgent cases. And so he was home on his own. So it didn't take long. By April 8th, he called in saying, "I'm really in trouble. Can I please come in?" So I brought him urgently into our IV clinic, as the wound clinic was still closed. I had been redeployed to acute care at that time, but was still able to bring the odd person in. And you can see that he had quite a serious infection going on. He had a really rapid onset of blistering. He didn't feel well. He didn't have a fever, but he complained of feeling unwell and that his heart was racing, and he had a significant redness, swelling, and tracking up his leg. So he was sent to the emergency department, and he was admitted to acute care, where he was awaiting an MRI. So you can see that significant purulence. You can see that he had a little bit, you can see a little bit of aquacellar acticoat here. Because I was redeployed to acute care, worked on trying to keep this debrided and appropriately managed with antibiotics. And we did see some good results. You can see that the infection is subsiding. He's still got deep wounds there. But again, because of the time that it was during COVID, his MRI was quite delayed. He did finally get that done. It showed a large abscess deep within his foot, and he was finally transferred to a large city hospital under orthopedics. You can see on the right that they did a debridement and revision of that transmetatarsal stump on April 18th, and he was put on 6 weeks of IV antibiotics at that time. So he remains in hospital. I'm sorry if you hear crying in the background. I have twins upstairs, so you'll have to forgive that. He had surgery. He came in to have his sutures removed after 3 weeks. And you can see here, when you look at this wound, he's coming in for suture removal. You can see that indeed this is not closed. And when we opened took the sutures out, he had a large hematoma, which was evacuated. It was 5.5 centimeters deep. And indeed it was to bone. So he was started on negative pressure at that time in conjunction with the surgeon, and another 6 weeks of IV antibiotics were continued. He came in on June 17th with increased edema and again redness and swelling up the forefoot. Negative pressure was stopped. We started with wound packing. He again had another 6 weeks of IV antibiotics started. He was very, very discouraged, very frustrated. And by this time, remember, he's 53 years old. He said he was ready for an amputation. And so this was June 17th of 2020. So, you know, after 3 years, by that fall of 2020, he was scheduled for an elective amputation. It was a really difficult decision for him, but he made that because he really wanted to try and get his life back. He needed to resume work to be able to retire, and he was tired of being sick all of the time. And as you can see by his legs being marked before surgery, he retained his sense of humor through that entire time. And this is Lyle. These are all these stories are shared with permission. February 2021, he finally had that surgery. And, you know, we've talked a lot about that. He did most of his amputation alone in the hospital. And truly, he was a COVID survivor of a different type, definitely. So really, where are we now? We're returning to this new normal, which I'm not sure really what that will be. But really, you know, reading literature and looking at the subject and listening to people, there really is a pandemic within the pandemic regarding foot complications for people with diabetes. And I really have seen this particularly, I would say, since January. The number of people that we're seeing that are coming in with very, very advanced foot complications that have not sought care or have not seen their family doctor since before COVID, having been, you know, into this for quite some time now. So it's been really difficult, I think, for people. It's been difficult for us as health practitioners as well. But, you know, there is discussion in the literature about identifying, triaging lower extremity risk. Who do we see and when? There's discussion about what we'll do moving forward and how we can manage this if it were to happen again. But certainly, I think we'll see more published and more shared as time goes with this topic. Just gonna have a drink of water. So when we talk about diabetic foot complications, really the essential components of managing those foot complications or those foot ulcers remains the same. So looking at treating that underlying disease process, good glycemic control is really, really imperative. And I've seen that really suffer during COVID. Ensuring adequate blood supply and looking at determining those wound goals. Is a wound healable? Is it non-healable, or is it maintenance? And many wounds we went to wound maintenance during that time or non-healable, deemed them non-healable because we just didn't have the resources to move towards trying to heal them. Local wound care, including biofilm and infection control, remains really important, and pressure offloading. We know that pressure offloading is absolutely essential to positive patient outcomes when a person has a wound on the foot, particularly on the toes or plantar surface. So the urgency of these clinical presentations can't be denied. We can look at each of these wounds. Here we have, an exposed Achilles tendon. We have serious infection. This needs to be dealt with in a more urgent manner. Here we have critical infection of a foot and toe with necrosis. This needs to be addressed. And here we have acute evolution of ischemia in a diabetic foot ulcer. And so these are all really urgent or emergent types of wounds that we know need to be dealt with in a timely manner. However, there's lots of other types of wounds that we also need to continue to care for. Here, I bring this up because it's really important. This was one of my type 1 diabetics who had an amputation related to an acute Charcot, and he actually dehissed this wound, the wounds below with the dressings, and this is Amiflex border flex, or as a result of him stepping down and dehissing that wound, which a lot of people who have an amputation will do. And so moving someone to where they have, a closed wound can take a long period of time. And this may not triage very, very high compared to wounds like this. Additionally, looking at hemorrhagic callus and new onset wounds is really, really essential. That early identification can really affect the outcomes for that patient. And so this is a lady you can see, again, she's a type 1 as well, but you can see she presents with a hemorrhagic callus. On the 5th met head, she has a wound on the 1st met head. You can see she's had a previous amputation. She only has 4 toes. And indeed, her foot is remodeled nicely enough that it's sometimes hard to tell unless you look quite closely. But with her, and this was pre-COVID, if we de-roofed that callus, so here you can see the wound, getting rid of all of the undermining and identifying the wound and treating it, optimizing treatment, and then also getting rid of that hemorrhagic callus. And that is immediately after removing that. And then seeing her within a week, you can see that the wound is largely closed, and that everything, really the outcome is very good. So how can we triage this less in a way than these kinds of wounds? This is very urgent and life and limb threatening, but this very, very quickly can become life and limb threatening as well. And so looking at that moving forward, I think the onus is on us to continue to look at people to try and get them to the places that they need to be seen to minimize these complications ongoing. It is a real struggle for people, and access to foot care services or even wound clinics where you would have this type of debridement done remains difficult. Really, what is very, very important when we're looking at people with diabetic foot complication is to really look and to see. And I've always really liked this picture because we see the farmer, but if we look more closely, we see his life within. And that remains really important for all of us during this time. We have to remember that we can't assess patients without touching them. Video conferencing is really important, but that hands-on assessment, that ability to have that casual conversation, that casual interview with a patient, there's really no substitution for that. And that when we see people in person, we're able to be better investigators. We're able to have better conversations and learn more about people, considering, are they smoking more? Do they have increased shortness of breath? We actually saw that a number of times during COVID where we had patients because they were wearing masks that we attributed shortness of breath to the mask. And indeed, when removing the mask and putting face shields on, found that people were actually more hypoxic or had COPD even that hadn't been treated for long since before COVID began. And so we know that many of our people with diabetes don't only have diabetes, they have other conditions like COPD and CHF. and they've had a difficult time during this. We need to really think about what level of risk is acceptable for people with diabetes and with foot complications, because what is the minimum standard of care? And that's something that I think we need to continue to think about ongoing. We also look at how can we support prevention while addressing acute need. And I go back to the cases of Our Lady with the callus in the wound. What is the minimum standard of care, and how are we going to facilitate positive outcomes from her so that she doesn't end up with an amputation like this or with a foot that looks like this? So things for us to consider moving forward. I did during the presentation, I didn't talk about any dressings, but you will have noticed that I did have a number of pictures of dressings through the presentation. Often we used Meplex BorderFlex, or we continue to do so, because for a certain reason for diabetic foot complications, and that is because of the silicone tacked through the whole dressing. So by using a large enough dressing, we can decrease that friction and shear around the wound, or that movement of the dressing on the plantar surface of the foot. And that is really very helpful. It's also very conformable. And I think we're lucky to have Flex now compared to Meplex Border. It has been a really good innovation because of its conformability and its ability to move exudate up into the dressing and allow it to evaporate through the top layer. I also am including just a really quick selection guide when we're looking at choosing dressings. There's a number of different enablers to do that. And I think moving forward, we may see some addition to some of these sorts of dressing guides in looking at self-care and what would be easiest for patients when they're having to provide their own wound care at home. There's often this discussion, I will get the question about drywall screen, and we've used drywall screen or drywall mesh in our clinic for many, many, many years for callus management. It gives us a strategy that we can share with patients. A package of drywall screen costs maybe $4 or $5 and is found in the hardware department or the paint department at Canadian Tire or wherever, Home Depot, wherever you are. They can cut this package into small pieces, and a package will last a person who's doing callus management for a number of months. And so we'll teach patients to do that, to cover their wounds, to sand around. But I think by supporting those self-care strategies in clinics or in home care settings can be very effective, because we never know when people are going to be stranded on their own, or when they're in situations where they may need to do more self-care or care for someone else. And so this is something that is really inexpensive and can give us something to use moving forward. I do include my references for my presentation, just so that there's a lot of really good research done, a lot of good discussion in the literature, and I think it's important that we continue to look at that and to read. And what I'd like to do is I'd like to finish up the afternoon, or the evening, I guess it's evening for you, it's afternoon here, is to answer any questions that you might have as we move forward.
Thank you, Michele. It was a great presentation. We're now going to begin answering questions. As a reminder, you can still submit questions through the Q&A box. There's a question here, Michele. What have you found to be the challenges to access product during COVID?
Well, I think that many of the vendors that sell product were closed. And there was also the whole supply chain issue as well. And so people weren't able to access things. They were also afraid to go out of their houses. Many people were not afraid to go out, but there were just as many who were afraid to go out, who were afraid to go to stores, and really couldn't access that. There's a lot of people who rely on others to change their dressings. For instance, many of our elderly, those that live alone, and people with diabetes because of poor sight often have difficulty with that. And so it was difficult for them to access. I know in our clinic, we gave a lot of product out. We recommended things like Amazon at the time, using other dressings that maybe weren't intended for wound care, like using baby diapers or using incontinence pads, classic liners, those sorts of things. But I think as time has went, our access to product has improved again. But again, we all see, times when we're not able to access things, but that education of where people can find things becomes quite important. So I think that's improved, but that was a huge issue for us, and I think for many others as well.
Okay, thank you. There's another question here. Is your clinic using any particular guideline to triage your DFUs?
That's a really good question. And there's actually a number of pieces of literature about triaging. And that is something that we've talked about. Our clinic is a nurse-run clinic. So there is myself as a nurse practitioner. There's RNs who debride, there's LPNs, we have a physio, and we have access to social work, dietitian, respiratory therapist. And so I had a blank for a minute. I've been listening to crying, and all of a sudden the crying went quiet. So it made me a little bit quiet as well. Can you repeat the question once more, Maria? I lost my train of thought.
No worries. They were asking if your clinic is using any particular guidelines to triage DFUs.
So my point was, because we're a nurse-run clinic, and our clinic is accessible by self-referral or by health practitioner referral, like home care. It does not have to be a physician. And so part of that remains is that I, as the nurse practitioner, do all the triage, and so have worked to try and set up some criteria for accessing, for people to access service. So during COVID, that was difficult. Now we're working on a more streamlined or a more concrete way of triaging. And it's always been that if a person calls in with diabetes and is complaining of callus that they can't manage, there's a lot more of conversation that goes into that as to determine if that callus is discolored or hemorrhaging, hemorrhagic callus, or if there's any opening or drainage. And so, that's often a fight when I have people who are not myself triaging, is to have them really look at those people is really important. And I showed you the case study of the lady with the 4 toes and the callus and the small wound. And I really strongly believe our triage should identify those patients as very high risk and seeing them in a very timely manner so that we can prevent those really dire complications that we saw in some of the other cases.
Thank you. We have a couple of questions about the drywall technique.
Yeah.
So could you explain again how you use that drywall sandpaper for the callus?
I will.
You make the patient rub the callus with the sandpaper?
We do. So let me just, I'm just going to go back a little bit, because I think I can give you a better explanation if I have an actual picture with that. So for this fellow, that drywall screen, you can see we've cut it into small pieces. We'll often bend it in half so that you have a smooth edge, and we would just get them to really sand over top of it with. It does work really well. Remember, things are sanded best dry. We don't sand wood wet, so it's hard to sand callus when it's wet. And even when there is actual wounds, we would have someone cover that wound and sand at least the callus around to try and keep that down. And so, yes, we do get them. We use it in our clinics. So we demonstrate that for patients, and we encourage them, and we'll have them do the, to demonstrate it back for us so that we can see that they're doing well with it. And indeed, encouraging them to change that frequently. So that little piece of screen, to use it once and get rid of it instead of trying to use, the sanding paddles or that sort of thing that are staying in showers and becoming contaminated. So it's been a very good strategy. People do take to it quite well, and it does give us something to work with patients on it. And as I said, the grit of the drywall screen just means how far apart the mesh is, how big the mesh is. And so I'm not supporting any particular brand. This just happened to be the packages that I had accessible, but it is a good strategy. And I would encourage you to try it on your own callus and see how that works for you before trying it on patients if that's something you're unfamiliar with, but certainly works good on your own callus as well.
Thank you, Michele. How frustrating or hard was it for you to move to wound maintenance for people just due to the lack of resources?
It's very, 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 very difficult. And I think for many of us that the pandemic and the things that we've been asked to do or the things that we've had to do because of lack of service it's been difficult for patients, but it's been very difficult on us too. And I think that it contributes to feeling burned out or to feeling like we're helpless in some way. And I think that's part of the reason why I really wanted to talk about this subject, was because I think it's a bit cathartic and it's good to talk about these things. It's good to know that we've all seen a lot of similar results, and maybe with different disease modalities, but certainly with people with wounds, we've seen a lot of very dire results. We've seen a lot of people who suffered a lot. And I would say, particularly since January, I've had 3 of my long-term diabetics that we fought very, very hard to save limbs with. We lost them during that time. And I attribute some of that to the impact of chronic disease management. They didn't get what they needed and really tried to just make it through. And so it's been very tough on many of us. And I think that's why it's important to share our stories.
Thank you. What are some of your favorite heel and foot offloading devices for folks who don't walk?
For people who don't walk?
Yes.
Oh, well, that's interesting. Well, if they don't walk, it should be easy. But I challenge, we have a fellow who doesn't walk, but he propels himself with his feet in his wheelchair. And so again, footwear is really, really, really important. And I could talk about footwear forever. So we love total contact casting. We love air cast walkers, but sometimes it's just getting a good fitting shoe and making sure that that shoe is that shoe or that device is secured well to the foot. I always look, the first thing I look at is people's footwear. And if they have slip-ons, I'm always somewhat concerned because it allows them to piston in the shoe. Or if they have shoelaces and aren't tying them up, I always bug them endlessly that they need to corset their foot in the shoe, not too tight, but not too loose. And so, that's can be very helpful. If you truly have someone that's not walking, then it's looking at pressure offloading in a different way. That may be looking at using offloading boots like Sage boots or Prevalon boots. If they're at high risk for heel ulcers, looking at prophylactic dressing use with good monitoring of those dressings, because no dressing, even if it's intended for pressure injury prevention, which in many ways diabetic foot ulcers are a form of pressure injury, but it's a person who has a lot more risk because of the diabetes, that dressings alone are not a good management, are not a good strategy for prevention. You have to do everything else as well. And so hopefully that has answered some of the questions, but I always challenge, you have to look for pressure where you find it, and you need to know the person's story, and you need to see how they're moving and what they're doing to determine really what the issues are. The why a wound exists should always inform what we do. And we can't figure out what we do or why it happens unless we get that story and we do that investigation. I think that's why we like medicine so much.
And actually, this other question is related to the previous one. So, how can you explain how casting works on draining wounds? How do they prevent maceration?
Really, when you're using total contact casting on draining wounds, it may be that they need to be changed more often. A total contact cast may stay in place for up to a week, but rarely. And with a diabetic foot ulcer, we've had to change them sometimes every 2 days. But it's also always looking at why the drainage is there and why the maceration is there. Is the wound draining because of unmanaged edema? Is the wound draining because of suboptimal management of bacterial load or infection? Does the person sweat a lot and it's not related to the wound at all? What's the temperature outside? The person is going to sweat a lot more and have a lot more presumed exudate when it's 40 degrees outside, which I understand it's quite nice in Ontario right now. So you may all have sweaty feet, but we really need to look at doing the work that's necessary to also get the offloading, but to manage the wound exudate as well. And that's choosing dressings that are going to manage exudate and choosing devices as well. And I will tell you, I've had people in total contact casting and had to take them out because of wound exudate and because their feet just simply sweat too much. And so it's always looking at talking and coming together to decide on what the best way it is to manage that individual person, because every person is a little different.
Okay. Any thoughts on remote patient monitoring? Was there any use in your clinic?
Oh, that is difficult. And so, the telephone, at least we had that. And continue, even now we find when we have remote patients, if they kind of go AWOL or we're not hearing from them, it's trying to identify a means of contacting them for monitoring. And that can be really difficult. In Alberta, we're going in the process to a program called Connect Care. So it's all online documentation, which has made it much harder to follow up with patients because, it's difficult to set programs just the way you want them to have them work the way that we need to. But those remote people, I think one of the things that's been good from COVID is the increased use of virtual medicine, using platforms like Zoom and Teams and those sorts of things. The real difficult part has been not having that hands-on care, or having, many of our elderly don't use technology, and they can hardly use. I know my dad can hardly use his cell phone. To ask him to go onto a video conferencing would not work very well at all. And so, trying to find ways of monitoring patients ongoing is really important. And I think really sometimes all we have is that telephone, and setting up ways of implementing that sort of a strategy for a patient load that you have is what's really needed, because they can't always come to you. Definitely. And now with the price of gas, they can't come to you either.
There's always a reason.
There's always a reason. Exactly.
So another question, do you refer your patients to a foot care nurse? As a foot care nurse, many of my clients can see the bottom of their feet and benefit from regular home visits.
That's a really, really good question. And foot care nurses, that was one of our real challenges during COVID, and it is now too. A number of them have went out of business or stopped doing it. In fact, we had a foot care nurse who did have a contract with our health authority and was coming into our clinic once a month to provide foot care. People had to pay for it, but the access to service was there. So we lost that during COVID. And I think, we have a list of foot care nurses in our clinic. It's not that we're, trying to have people go to one nurse over another. We'll put anybody on the list, but we are encourage people, and in fact, sometimes negotiate with them. If we're not going to continue to provide dressings and provide care if you're not going to get your foot care done, because that is such an important part. And I'm really happy that people are getting foot care services again. You can't do without it, honestly. You're muted, Maria.
Thank you very much, Michele. I think that I don't know if anyone has any other question, but thank you very much. It was a very engaging talk, and thank you everyone for attending today's webinar, Challenges in Diabetic Food Ulcer Management and the Impact of COVID. If you have any other question, you can contact Wounds Canada at info@woundscanada.ca. Here is a link where you can get Mölnlycke's product, pharmacy to home. They are shipped directly to your closest pharmacy. And these two emails below is if you have any additional questions or you need more information about our products. On behalf of Michele Labbie, Mölnlycke, and Wounds Canada, thank you very much for joining us today, and have a great rest of your day.
Thank you, Maria. And also, do you think that you could just, the pharmacy to home, is that a Mölnlycke website where then they ship it out? Or is that?
Actually, no, it's a third party. They have products from different brands, but it's also like our preferred vendor.
Oh,
so
nice. Okay.
Whenever you need one of our Mölnlycke's product, you can acquire it there.
Okay, thank you. I had to have my own questions. So
yes, but that's great. It's a great question. So yes, they ship it directly to your closest pharmacy, and yes, and it's in a very quick time.
Thank you very much, Maria.
No, thanks to you, and thanks everyone for joining us. Have a great evening.
Yes, and thank you. And I'm sorry about the twins in the background.
No worries.
Okay. Good night.
Thank you. Bye.